Well, good morning. I have to ask this question. How many of you are legal residents of Albany County? Uh-oh. All right. How many of you have ever lived in Lubbock, Texas? Good, I can be insulting towards Lubbock, Texas. As Courtney said, Lubbock supplanted McAllen, Texas, as the most expensive healthcare community in the country in the recent Dartmouth studies. My wife, who also spent time there in her youth, and I were chattering about this at home, and I opined that had I been forced to stay in Lubbock, Texas, and please turn off the camera, I probably would have been contributing to those high costs, and much of it would have been alcohol related. So that's my contribution, Wendy. Clearly, there's an immense amount of uncertainty about where this is all going to turn out. I particularly appreciated Tim's not only date stamping, but time stamping his presentation on much of what we're here to talk about, and much of what I won't talk about today. The simple answer is, I don't know, we don't know. You probably ought to ask again 3 months, 6 months, 3 months after a final bill is enacted. Having said that, and before getting into the specifics, I think we really need to acknowledge that we are at a special moment. As Courtney said, I've been banging on these issues and been banged by these issues for now 30 years. Wendy noted that we currently have 2.5 million people in New York who are uninsured. When we did the very first study of the uninsured population in New York, using 1980 data, there were 1.5 million. That's an increase of 1 million. It's actually been higher. So if you look at the internals of the numbers, private coverage has gone down markedly. Public coverage has gone up markedly. But still, today, we have 1 million more uninsured New Yorkers than we did 30 years ago. And by the way, the U.S. numbers, the nationwide numbers that were counterparts to today's 45 to 50 million uninsured back in 1980 were 26 million. So doing something is decades overdue. It is decades overdue. And it's not only on the coverage side, it's on the cost side. And as Tim indicated, there's a lot more ambiguity about what any of these bills may produce than in terms of cost savings. And that will increase my anxiety levels in my current role. In the first of the areas that I want to touch on, I want to touch on 3 areas. I want to touch first on the county role as an employer. And note also that overwhelmingly in New York, the same issues will apply to virtually any public sector employer. Now, the Medicaid stuff won't apply to school districts or towns or cities, as they will to all counties. And the third issue I want to talk about, but employee benefit costs will. And do not underestimate the impact of that. And I'll give you some hints. And I do want to touch on Medicaid and Family Health Plus and Child Health Plus. And since there's so many of you who are Albany County residents, you may have heard a rumor that we own a nursing home. Yeah, that's what I was afraid of. So I want to touch on that too. Let me give you some context. First off, Albany County, in the coming year, 2010, is looking at total appropriations in its budget of about 574 million. Off the top of my head, adjusting for our base Medicaid obligation, putting aside the temporary relief we get under the federal stimulus legislation, is 58 million. Total appropriations for our nursing home, 33 million. Our health benefit costs for our employees and retirees, 38 million. I.e., our health benefit costs are greater than our nursing home costs. And by the way, you all remember just a few years back when the growth of Medicaid costs was the local finance issue. Our health benefit costs since the Medicaid cap have grown 2-3 times faster than our Medicaid costs. And on a per dollar basis, it's about double. Our base Medicaid obligation goes up about $1.5 million a year. Our health benefit costs are going up 9 and 10% per year. That's on a base of mid-30s. So we're in the $3.5 to $4 million per year increase in our benefit costs. That's the increase per year. And I dare say that you can look at any municipality in New York State and you will see similar patterns. They may not be quite as dramatic as ours. In some cases they will be worse, but they are real and they are substantial. What I did not touch on is a no longer obscure provision of the Governmental Accounting Standards Board's requirements that we now have to at least account for the liability that we are accruing for health benefits for retirees. And for those of you who, might worry about such issues, we don't have to fund those liabilities. We have to fund our expanding liability for pension costs and send millions of dollars each year off to the state pension system. You're grabbing your pocket too. We don't do anything comparable for the increased liability for retiree health benefits 5 and 10 years down the road. But let me give you some context for that as well. I said that our employee benefit, our health benefit liability, or anticipated cost next year will be probably 38 million. If we were putting aside enough money so that our circumstance did not get any worse, we would be putting aside another $22, $23, $24 million. We are not. And given the activities in county budget making over the past couple of weeks, we're putting away less. If we were to amortize the liability that we have already built up but not funded, and I'm just talking about the annual cost of the amortization, that'd be another 30 million. Are you all beginning to get a sense of scope? If we were take our current liability and what we ought to be setting aside for retiree liability, we are now at a level that is virtually equivalent to the entire value of the 2010 county property tax. You all see why, yes, I'm personally thrilled that we are talking about coverage expansion, but more than a little anxious about costs and how federal reform will interact. We currently have about 2,400 active employees. They have obviously dependents. We've got about 1,000 current retirees. We are in active discussions with some municipalities which are interested in participating in our health plan. Just so, I mean, obviously the state of New York is the largest employer in Albany County. And then you can look at a couple of hospitals and a couple of health plans that are headquartered here. They are bigger. The next largest employer after healthcare organizations and after the state of New York is us. And these are the sort of scary numbers that we're concerned about. Now, there was earlier reference to the potential effects of federal reform on this side of the employment picture. Tim in particular talked about the pay-or-play options. That's to get employers who don't provide coverage or don't provide an adequate benefit to do so, or to provide some other mechanism to get those folks covered. At the other end of the spectrum are employers, and I would be willing to wager that overwhelmingly this is true of municipal employers in New York. We are at the other end of the spectrum where we spend a lot on health benefits. Now, how is that relevant? Well, the House bill pays for much of what they propose by increasing taxes on high-income folks. Various of the Senate bills do something a little different. They impose an excise tax on high-cost health benefit plans. Various people refer to them as Cadillac plans. I prefer to be more neutral. So starting in whatever the base year is, and there have been various proposals, for an individual, the cost of a health plan in excess of $8,000, there are other proposals, $8,500, would be taxable. Any dollar amount above that threshold would be subject to a 40% tax. So if your health benefit, if your employer buys a health benefit for you today, that comes to you as something, as non-taxable compensation. It does not show up on your W-2 like your wages or your salary. If this excise tax is implemented, let's say that the threshold for the excise tax is an $8,000 plan, and let's say your plan is $9,000, then somebody is going to get dinged for $400 worth of tax liability, i.e. 40% times 9,000 minus the 8,000 threshold. I don't know whether or not this is going to show up on your W-2. We're self-insured, self-funded, so we haven't even begun to think about the administrative aspects of how this is going to work, or for the economists in the room, what the tax incidence is, who's ultimately going to wind up paying. But for the moment, let's assume that it's going to be the employee. Oops, their taxes just went up. And so the secondary effect will be, I guarantee it, they're going to come back around when it's collective bargaining time and say, oh, we need to have our wages increased. And those wage increases are also taxable. So we're going to get caught up in this complex hydraulic system. That will be the first effect. Now, the economists will say, the basic idea here is to get employees over the long term to say, you know what? it is now tax neutral for us. Maybe we'd rather have the next increase not as expanded health coverage or maintenance of our current benefit plan, which is the cost of which is growing at 8, 9, 10% per year. Maybe we'd rather have the cash in our pocket because there's no longer a tax benefit for us. And note, and this is one of the things that we observed when we did our first study 30 years ago, the more expensive the plan and the higher the compensation of the individual, the greater the current tax advantage in taking the health benefit. The current tax benefit doesn't do much good for somebody who's barely making something over minimum wage and has a very marginal health plan. They don't get much in dollar benefit. A high-cost person with a high-cost plan that is currently non-taxable does get a substantial benefit. That's going to begin to go away. And when you look at municipal and governmental employees, especially in New York, generally, we have really good health benefits. All you state folks with, who have the state plan, heads up. At some point, you're going to say, wait a minute, maybe I'd rather have the cash. So the idea is to put some back pressures, hydraulic pressure on the plans and ultimately on those who are generating the cost, which, even though this is a Rubik's Cube of a system, it all ultimately comes down to the price of the service times the volume, the rate the service is used by individuals times the number of individuals. Well, we're going to have expanded numbers of individuals. No state has experimented with healthcare price controls like New York, so with varying degrees of success. So it all ultimately comes back to how do we control utilization without getting into arguments about rationing and those sorts of things. So right on the face of it, this is going to be complicated not only financially and administratively, but politically in terms of who bargains for what. We also don't know, and I mean in this case we really don't know, what the implications of this may be when we provide supplemental benefits for retirees. Because we do. If you retired early enough from Albany County, yeah, you get Medicare, but the county provides a wraparound so that your total benefit package is at least what it would have been had you continued as an employee. And in fact, Medicare even pays us back because of our pharmaceutical benefit, which saves them Medicare Part D pharmaceutical costs. So that one's going to be complex. It's going to ripple outside of the healthcare system into collective bargaining, wage issues, and so on. And if the Senate, if any one of the Senate versions is the one adopted, I am fully confident that Albany County, and I would wager the vast majority of municipal employee health benefit plans will exceed that threshold by the time it's implemented. So heads up on that one. Second, Medicaid finance and administration. Well, you all know that we still play a significant administrative role, and we still have a lot of money on the table. We're not as crazed as we were a few years ago. Except, of course, when we hear rumors that, gee, maybe, and yeah, I'm looking at you, maybe the pressures on the state are so fierce they would have to back off the commitment they made to counties with respect to a cap and growth in our liabilities. Now, I do not expect that to happen in the near term. I don't expect the governor to change direction on us. However, so long as aggregate Medicaid expenditures are going up at the rate of growth in our rate, that means the state and the federal government assume the cost of every single extra dollar in expense, which puts increased pressure on the state, which, and we're back to hydraulics. I keep having an image of a toothpaste tube, you know, and we're at the end with the cap, and the cap is off. Well, if you can't come back and hit us on Medicaid, just basic hydraulics say it is inevitable that there will be reductions in what the state makes available to municipal governments of all stripes. We will gnash our teeth, we will yell and scream, and worse, but let's think about the math. Let's think about something else here. Wendy talked about the different levels, the different eligibility standards as compared to the federal poverty level for federal aid. For, we're talking about 133% of poverty, we're talking about 150, or we're talking 200, or whatever. She went into those questions at some length. There's also a potential ripple there. There's potentially an administrative ripple, but in terms of the finances, I want to touch on something that may or may not show in government accounts. And let's call this the Moynihan effect. Many of you will recall that the late Senator Moynihan used to put out an annual report which described not governmental expense, but what New Yorkers were paying into federal coffers through their taxes, and how little of that was coming back to New York, and how much of that was going to predominantly southern states, although in that era, it was mostly because of defense spending. And Wendy gave us a good example or two. We're now going to, knock wood, we're going to have a significant expansion of coverage across the entire country. That is going to come out of, one way or another, federal revenue. If New Yorkers, not New York government, but if New Yorkers contribute a disproportionate share of federal revenues, and if those same states that have been, let's use the word, neglectful of their Medicaid programs, now see significant expansions of those programs, that means, again, hydraulics, we're going to be pushing even more money, a la Senator Moynihan, out of New York and into Alabama, Louisiana, and, geez, I'm back in love with Texas, which has the highest proportion of uninsured people. Texas is the state with the highest proportion of uninsured in the entire country. So if a significant percentage of them get covered as part of federal reform, we New Yorkers, not New York government, but we New Yorkers, we New York taxpayers, are going to be paying a disproportionate share of that benefit. So that one may be off of our books, but it will mean that our citizens are going to be even more distressed about even the hint of a tax increase to take care of our problems. Lastly, at least for today's discussion, I want to spend a moment on long-term care. God forbid Now, you all know that there are 40-plus counties that have at least one nursing home. I don't know the number, but a declining but still noticeable number have home health agencies. So here, even when we're talking about Medicaid costs, we're shifting roles, and counties are now the recipients of revenue. A little conflict of interest over the long term. And the Senate bill in particular, but both, has a number of substantial provisions. Senator Schumer has played, as I understand it, a substantial role in expanded funding for home and community-based services. Not expanded funding for institutional care. In fact, $0 in expanded funding for institutional long-term care. There is a new acronym, for those of you who have not been following it, CLASS, C-L-A-S-S, Community Living Assistance Services and Supports. New funding there. Expanded funding for the Money Follows the Person program. New state home and community-based service options. A new community first, quote, community first choice, quote, enhanced federal match for home and community-based services. No new nursing home money. Yeah. Well, this obviously will have a bearing on county finances and decision making. Let me close with a couple of open questions. I already hinted at what are going to be the tax effects vis-a-vis our employer status. Second, what will the state decide with respect to Medicaid? What will the state decide with respect to administration and finance regarding the Medicaid program? We can't, even if we read all the federal bills, we can't even project what the likely effect is on us until we get a sense of what the state's doing. Although our office joke often references the fact that we are literally, as well as figuratively, downhill from the state capitol. Will we take advantage of new opportunities in the legislation, for example, to expand home and community-based services? And lastly, will the cost control provisions actually make a difference? Will they bite? And when? I started by talking about the fact that today we have 2.5 million uninsured, whereas 30 years ago we had 1.5 million. To me, the simplest explanation of why that is not changes in the structure of the labor market, although that has an effect. It's that health benefit costs, health insurance premiums, Medicaid costs per capita have grown much too quickly for us to be able to afford it. And inexorably, as the price goes up, fewer buyers, more people have fallen out of the system. And the crisis we face today is a result of that. Will the cost control provisions of federal health care reform actually make a difference? If not, we will be looking at a far bigger mess than we are today. Thank you for your time and attention.